To this webinar. This webinar, as most of you know, is part of the Collectivity series on governance for strategic purchasing that's been moving through 2019. You can see on the screen now the series in its full and where we stand now and what's coming, and we'll run through some of the upcoming webinars near the end as well. And for those of you who are unfamiliar with Collectivity as a platform, Collectivity is an online platform and tool that facilitates the achievement of virtual collaborative projects to help support collective learning. It's open to anyone who's interested in learning through virtual exchange. This governance for strategic purchasing webinar series that we're a part of now is one group that's posted on the Collectivity platform, but there are other topics and other groups that are also moving forward. It's very interesting, great collaborative platform. So I encourage those of you who have not visited to check it out and see if there's anything that piques your interest. So for this series, each webinar is being presented with a country case study that's going to highlight key aspects of the WHO framework to assess governance for strategic purchasing, which is forthcoming. I think there's a conference copy that's circulating. And Yaker, someone is saying that they can't hear anything. Can others on the phone or on the line rather hear me? Orly, are you able to hear me? You can hear me. Jaker, maybe check the connection. Sumit also can hear me. Excellent. So the webinar series is focusing in on different elements of strategic purchasing to explore how governance arrangements can contribute to making purchasing more strategic. So this particular presentation will focus in on experience with governance for strategic purchasing in India, and is focused on answering the following question, which we circulated to all of you in advance. What specific governance aspects, including the political and institutional drivers, are critical for the expansion or initiation of strategic purchasing instruments in India? So to hear about this question, we have Sumit Mazumdar, who's a Global Health Research Fellow at the Center for Health Economics at the University of York, who's going to speak to us about the experience of India, focusing on this question, as well as elucidating how strategic purchasing can help to act as a quality lever in his presentation. So he'll speak for approximately 20 minutes. Jaker DeClaro, who's a senior health financing advisor for RTI International for their family planning and maternal and child health project in the Philippines, will then respond to share some experience from the Philippines along those lines as well. Between the two, I'll repose the question, and we would like to invite participants on the line to respond within the chat function with some relevant experience from their own countries, which we can then document and share. We'll also move into a question period and would invite those who are sharing their experiences over the chat function to speak more broadly about them. And we'll also perhaps call on some who are flagging some interesting experiences. Of course, you'll also be welcome to ask any questions to both the country presenter and to the discussant. So with that, let me pass over to Sumit and we will get started. Sumit, over to you.
Good afternoon, good morning, depending on which part of the world you are joining in from. Thanks, Daniel and Aurelie, for this webinar. Without much ado, I would just I'd like to start my presentation, which I hope everybody can see the slides. So it's broadly on as Daniel said. We'll talk on the governance aspects of strategic purchasing, and this is authored with Dr. Jain Nishant Jain, who works with the GIZ India in New Delhi. So Um, the, the 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 two questions, the main two questions which we'll be talking about in the webinar through the country case study for India is number one, is what specific governance aspects, including the more political and institutional drivers, which are critical in the implementation and expansion of different strategic purchasing instruments. And we would talk about some of the government sponsored health insurance programs in India, with some reference to the new program, and then briefly touch upon how strategic purchasing in the health sector could be a potential policy lever to influence quality of care, especially in the private sector. So we will give a brief feature of Indian health system for those who are not familiar with it, and then introduce some from the existing programs which have been in operation in India, some of the health financing reforms programs in the last decade or so, and then talk about the new program which would be the main focus of today's webinar. So um, for those most of you who might be having some idea about the broad feature of Indian health system, but if not, so it's some of the relevant, there is quite a lot of issues, but for what would be more pertinent is some structural issues. For example, like uh, more than I mean, almost a fifth of I mean, less than a fifth of the Indian workforce is in salaried jobs. So, uh, unlike many other middle income countries, having a social health insurance scheme in India is not feasible. Uh, Service provision in India is highly fragmented. So we have both a mix of a public sector which operates through three tiers of health facilities, right from the primary health centers to district hospitals, sub-district hospitals, and medical colleges, which are big tertiary level health facilities. At the same time, there is a highly diverse private sector, which is very weakly regulated, and so there is, and as it stands, like you can see some numbers like in the screen, that the service mix is heavily skewed for private sector, while in public sector hospital services are mostly free, although there are some cases of user charges, but in general public sector are of uh, comparatively poor quality, and services are not available commensurate to demand. So there has been, you can see the switch towards private sector for both hospitalized and non-hospitalized uh, issues. One important issue which will come back is, as I said, is a weak regulation of the private sector, which means there is the costs of treatment are highly diverse, and there is very weak standardization of prices as well as treatment quality, and there is very poor gatekeeping role for the health system. So it's complicated and makes it huge challenge for any reforms. So as you could see, like the government sponsored health insurance in India has progressed through different programs. There are these a lot of state level programs. You can see the UHIS, the Arogyasri and all. So first time at a national level, which it started mainly with what is called as the Rashtriya Swasth Bima Yojana, the national health insurance program, which started in 2008. And there were a few state level, you could see the programs, Arogyasri and Vajpayee and all, they were more state level programs. So they started. So, but until about a couple of years back, mostly it was dominated by private sector voluntary insurance. So with uh, kind of mostly provided through private and public insurance companies. Uh, so, so if we try to that which aspects of thinking of these financing reforms as the way the health insurance programs measured in India, what are some of the key aspects of governance? Talking of governance, are relevant for the reforms. Uh, First is we need to understand that the typical federal administrative structure in India, which means like health is a subject which is to be legislated by the states, which mean like in India there are governments at the provinces or the states we call them, and the national government. So the national government makes the broad laws and kind of is responsible for national health programs, but mostly the programs are run at the states. So there are these kind of although there are very detailed constitutional provisions on who does what, including sharing of the financial responsibilities, but often there is this complication, like it's not always very, and mostly due to political affiliations, where at some cases if the political government in the national and the state level are not aligned on the same line, then there are at times conflicts on what programs are implemented and how. Uh, there has been from 2005 at least, in a major way, a lot of emphasis on involving local governments like municipal governments, district governments in decentralized policy implementation. But that raises a lot of issues for capacities and accountability, because at the grassroots level, at the local level, a lot of technical administrative capacities are not that strong for across the country given the size. uh, there are also important for how the Indian bureaucracy is organized. There is a lot of hierarchies, like many of the middle income countries. Decision making processes uh, is often suffers through a lot of red tapeism. There are frequent transfers. So in the way the bureaucracy which implements the programs as health administrators has big implications on how it's governed. And of course, and there is high heterogeneity among purchasers and providers, so it's always a challenge to align incentives. But mostly it is the influence of political agency and will which uh, affairs, and there is both ways in which they could affect through political agency as well as through interference and rent seeking. I'll quickly move through the early experience of the health insurance program. So as you could see, we started with RSBY. It was very limited passive purchasing, like it was a certain identified poor households were entitled for some services, which roughly about $500 per year per family. There was a more passive purchasing from mostly private hospitals, and they were reimbursed on a fee for service scheme. Of course, one big issue was limited coverage in terms of the financial coverage this program extended. But at the same time, there were issues of weak local capacity, as we have been saying, and poor mechanisms how, so that the results from, and there are a few papers which shows like the impact of RSBY on out of pocket expenditure, for example, is not very straightforward and not homogeneous across the country. And there has been allegations like in some states there was a bit of corruption and fraud, and the system was misused. There were the two states which I won't spend much time here, but so that there were other state level uh, 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 you know schemes which tried with a bigger coverage than RSBY, and had tried. So these were around 2010, where these states tried some more purchasing from the private sector, but these were limited to certain states, but not at national level. So, based on these experience, what the key lessons which were learned is that in whenever scheme, in whenever state, the performance is very dependent on how the overall health system governance works. So, health insurance or a health insurance program, even if it had a specialized structure, doesn't work independently of the wider health system. Strong institutions are important. Political support is very key for implementation. And in RSBY, for example, there was a dedicated institution at the national level was not set up for stewarding and controlling the program. And of course, a strong IT platform is a key to success. So, with this thing, like in the next 10 minutes, I'd like to talk about the new program which was started last year. We just completed the anniversary yesterday for the program called as the Pradhan Mantri Jana Arogya Yojana, which translates to the Prime Minister's public uh, illness cure scheme or something like that. So it's basically a national health insurance program which was rolled off last year, and you can see the coverage in terms of the numbers as well as the amount is significantly vast from RSBY. It aims to cover about 500 million poorest population, significantly scale up the services. The basic model is the same. It would be operated by in different states, either through an insurance company or some autonomous public agency who would be purchasing as a so at the state level there would be a single purchaser who would be purchasing services from, and it's useful to note it is only for services for treating at hospitals. So you don't get this insurance if you are not admitted in a hospital, no, except a few daycare or things like that. So it's mostly funded to general tax revenue. You can see how the funding is shared. Overall, the stewardship on a lot of the issues are being provided through a national nodal agency called National Health Authority. I can explain if there are questions. And as of now, there are it operates except 4 states. It's most of the states that you can see the number of hospitals empaneled. So it has been expanded significantly. There is a brief layout of how the process flows, and look back to it later. So it's basically you can see the two important takeaways is there has been certain layers of scrutiny, checks and balances, uh, using a more IT platform of verifying the genuineness of the beneficiary, as well as pre-authorizing the claim which was raised by the hospitals, and different structures and including feedback call. So a lot of mechanisms has been built in the process flow so that to discourage frauds as well as to increase transparency and better governance and in functioning of the overall scheme. Uh, Knocking off the purchasing architecture in PMJOI. So at each state there has been these hospitals have been empaneled by a committee called the EADC, which look forward to kind of based on a very stringent criteria. Hospitals have been empaneled to be as a network providers under this scheme. A specific criteria for most of the claims, except a few where hospitals are required to avail pre-authorization. For the kind of medical procedures to be conducted, they are paid. It is mostly a fee for service. So, like for every procedure which is provided, there is standard fees which is being paid. Uh, and there are insurance companies who carry financial risk or ISAs are selected to support the state health agencies. And I'll just talk the next bit on this on so there has been some incentive for hospitals to upgrade their quality and get some added incentives. So, and quality certification is based on a very rigorous a scale by the National Quality Council. Now, the couple of the few governance considerations which you can see is basically we need so both steering, which is more like a stewardship oversight governance functions, as well as more operation, and you need both in purchasing under PMJY. So, for example, you need more decentralization scheme. It's not only strategic purchasing but strategic regulation. Given the kind scale of India, it is important that there are harmonized efforts between national state agency so that the private providers, because I think a big implication of using strategic purchasing as a policy lever to influence quality is first by harmonizing and kind of trying to bring in some regulation, some harmonized action across the private sector, and through different means of encouragement, incubation, and incentivization, also encourage some amount of competition and gradually towards some more performance based or result based framework. There has been a lot of global experiences of that. We can talk about that, how you can move more to an outcome based rather than a result based framework. A lot of more day to day performations like using IT systems, strengthening the district units, human capacities, technical capacities, managing first turnaround. In India, everything has a huge scale. So how you manage for high volume claims, a lot of operational governance mechanisms are associated with financing, pushing a lot of national demands in, for example, managing claims, clinical audits, hospital scrutiny. So it's a mix. You can see it's a tough challenge laid out there. It has been since the focus of the webinar was on quality, so it's available on the web. So very recently, the government had started under PMJY to formulate a comprehensive set of guidelines for hospitals to get a graded quality certification. Is very comprehensive. A lot of 53 indicators, and then need to do verification indicators like how can you verify of a quality to be that, and there will be independent teams that would be verifying and submitting claims, and so it aims to transform the quality landscape, particularly for the more small scale health facilities, and incentive as and better financial benefits. So there are a few other policy levers. A very important thing has been using the standard treatment guidelines and care pathways, which is extremely important thinking of the health guideline. And there has been a lot of emphasis under PMJY to implement this. It is still early stages, but it's still very much there and is up there. A lot of emphasis also into widely implement the clinical establishment rules, which is more like having stringent measures for regulate the private sector quality. A combination of physical surveillance, IT surveillance, a set of reports have been provided involving insurance regulators and agencies. So how you could monitor and surveillance claims through more comprehensive audits and check frauds and regularities, including mechanisms for feedback and grievance redress. So this is a final slide. So looking for what the challenges and opportunities. So it's both, as you could see, there are opportunities ahead as well as challenges ahead. The first is, I think, the challenge is for promoting harmonized health service ecosystem, single payer model. Of course, expanding coverage, developing new IT systems are operational challenges, and I think we're very soon coming to a stage where PMJY and the demand would and the governance challenge would rise manifold if you think of linking primary care with PMJY, which is more outpatient ambulatory care, and how to develop the continuum of care as well as ensure quality and uh, acquired stewardship across this continuum. Finally, like encouraging and incentivizing more performance based metrics with outcomes in both purchasing and payment. So it's not gradually moving from. And here I think it's very important. The role of HTA would come, how you move to more cost effective purchasing, and then again which links in the institutional demands of the capacities. The final word is like you need to combine both the steering and the rowing roles in the governance. So just not stewardship, you have to get hands dirty in getting operational rules, but also have the oversight and organize. Use this national huge insurance scheme which has been built as its largest health insurance program, is to use it as a lever to kind of sure that you can use purchasing functions as a lever that can ensure equitable universal coverage with quality, which as we all know has been a talk of the day with the UN sessions in New York. Thank you very much. We look for your comments and feedback, and here for email and suggestions, as well as our feedback at the details and the find the next webinars. Yeah, thank you very much. Look forward for your inputs.
Thank you, Sumit. That was an excellent presentation. Very interesting to hear from you about the balance between steering and rowing and this new quality certification processes being put in place in hospitals. I think that's a very interesting reform. Um, we are going to pass it now to Jaker, who's going to speak about the experience in Philippines. And as a reminder, he's responding to the question, what specific governance aspects, including political and institutional drivers, were critical in the expansion or initiation of strategic purchasing instruments? And again, at this point, you are all welcome to, if you have any relevant country experience that you wanted to share linked to the points being raised or otherwise, to start raising those within the comment section of the chat function on the WebEx, and we will then move into a discussion period where we can share some of those more broadly. So with that, Jaker, over to you.
Thank you very much, Danielle. Um, and of course, I would like to thank Sumit for that excellent presentation. Uh, as you all well know, while I was actually listening to the presentation of Sumit, I got a number of things that are actually similar uh, in the same context in the Philippines. So more or less, India and Philippines is very much similar context. No? High informality, which affects the risk pools of the health insurance, weak price regulation, and high out-of-pocket spending. There's poor quality of services from public sector providers versus unregulated price of services from the private sector, which is a bit or private sector, which is quite dominant. There's a weak gatekeeping function, referral mechanism, and all of these things are operating under a highly decentralized setting. Now, so similarly, no, the Philippines also has this undergoing this same or experiencing the same issues, and I find the presentation of Sumit quite interesting in a sense that it also presents a lot of progress towards consolidating a number of reforms in India, particularly in their health insurance aspect. And there are certain insights from India that could also be quite true with how the Philippines actually also moving forward with these reforms. So, given the question earlier that was posted, I'm going to frame my discussion on this particular topic, emphasizing more on the political and institutional drivers that actually were critical also in expanding strategic purchasing, similarly to what India was actually doing here in the Philippines. I would just be probably just pointing out three or four the most points, uh, uh, tying it up with the experience of India and as well as uh, injecting some lessons learned from the Philippine experience. The first one is that the national government has to take a greater role in terms of stewardship. Uh, Stewardship is a very important governance function. And when we talk about stewardship, what I mean is that uh, the the reforms are prov- laid down. There's, in terms of planned reforms, in terms of the desired goals, and in terms of the outcome. There has to be somebody who has to take a greater oversight for all of these things. As earlier mentioned by Sumit, uh, the, the national government objectives should be linked to what the state level objectives in terms of the health reforms and objective to what they're actually desiring to uh, achieve at the end of the day. So I would like to really emphasize here the need to adopt a whole of system, whole of government approach as a governance framework in addressing fragmentation in the health system. Similarly, in the Philippines, what we actually did is uh, a primary legislation was put into effect. We call this the Universal Healthcare Act. This was just recently passed in February of this year. Uh, it actually defines the reforms that has to be instituted in the health sector, and defining also the specific actors, including the roles and the responsibilities of each and every actors in the health sector. So this includes the national government, what the local government should do, the purchasing agency, other private health insurance also is doing purchasing functions. So this puts into motion a countrywide policy and direction, including governance mechanism for achieving universal health care. Uh, and and the good thing about this is it provides clarity in the roles of the different players, and it states the oversight role of the national government. It defines who pays for what in terms of the purchasing function of the national health insurance and the private insurance as a complementary uh, complementary body or organization. Um, the providers and the rest of government instrumentalities. No? So it's very important to uh, uh, emphasize that the national government has to take that greater role, not only in financing but in overall stewardship of the healthcare system. The second one is building the capacity of the local government to be more responsible for their state level health system. This complements well with the first point. The national government has to take an active role, primarily in terms of financing. And it's a really a good thing that in India there is a sharing of funds between the national and the local government. The Philippines did that also a few years back, and right now it's the national government is taking the much bigger role in terms of financing by using novel revenue domestic resources, generating more domestic resources through sin taxes. Uh, but the second point is that we have to build the capacity of the local government to be more responsible for their own health system. And this is very true for many decentralized countries and setting. There are this is very important to capacitate the local government because they are in a better position to address informality uh, in terms of from an economic point of view, and also define the healthcare needs of their constituency. What we do in the Philippines is that we are actually using the local investment plan for health as an instrument to link their own uh, state level health system objectives with that of the national uh, health overall health reform agenda. And this also would be a really good opportunity to benchmark practices across different states. Uh, in the Philippines, we are just starting to do this one. We are looking at how the different state governments are actually implementing their own reforms. Uh, we provide incentives for them to do that. We consolidate it at the level of the provincial, or what we call the state level. So uh, all the reforms has to happen at that level. It is more efficient, and if we thought it will be more efficient and effective at that level, rather than allowing municipality or city level uh, uh, reforms to happen. So if we're going to consolidate at the level of the provincial, it will be more efficient in terms of the financing, and there will be less overlaps. We'll be able to consolidate also the governance mechanism at the state level, and accountability also will be at that level. Uh, so in terms of building the capacity we of the local government units, we also see that defining what the local government finances and what the national government finances is also very critical. We defined it here in the Philippines as those population-based services should be financed by the local government units or the state level government and the national government, but the individual level healthcare services should be financed by the health insurance. So this actually, you know, delineates the financing functions of national, the local government between that of the uh, social health insurance or the insurance or purchasing agency. Uh, Now, I'm pointing this out because this is very important in terms of giving the health social health insurance greater leverage in terms of financing that will actually dramatically influence public sector performance. For quite a long time, the Philippines is having difficulty in terms of consolidating the finances because there are a lot of uh, services that are being paid for by a number of uh, government instrumentalities or agencies. So by delegating this consolidated fund to a central agency, in this case, it's the social insurance. It gives the social insurance more leverage to negotiate for prices of healthcare services from its accredited healthcare providers. Um, and also, the right mix of provider payment and incentive is central in shaping behavior of the providers. Uh, for a long time, the Philippines is using fee for service as a paying healthcare providers, but now we have dramatically shifted to case-based payment and moving towards DRG as a more prospective payment mechanism. But also, we're looking at integrating a global budget scheme to be able to download funds and money at the level of the state level so they can public sector providers be able to improve their healthcare services and system. Uh, Probably as the last point, I would like to zero in on an accreditation contracting as an important instrument for negotiation. Uh, it's very interesting to note that in India, they have this what we call differentiated premium rates based on continuous quality improvement as a very interesting feature. We don't have that in the Philippines, but we are actually right now using contracting as a means to encourage providers to work as a network. So we are looking at the possibility of not contracting individual providers, but we are now contracting a network to ensure that the referral mechanism would be more sustainable in the long run. Uh, uh, the network should be composed of primary care services, the secondary and tertiary care services. So one whole network is already able to navigate the any any person along the complex healthcare system. So by using contracting as a means to negotiate for uh, not only quality health services, but for the kind of services that we want, and also ensuring that the referral mechanism is sustainable in the long run. We are now looking at accreditation or contracting provider network rather than individual healthcare provider or an individual facility. Uh, I think lastly, I'd like to also point out accountability mechanism should be designed as early as now in terms of using a number of uh, key information that should be made available. Costing data should be collected. If like India would want to move to from fee for service to different type of provider payment mechanism, costing exercise is a very important step towards that. Transparent pricing, the costing of services is a very important mechanism, important step towards cost effective, moving towards a cost effective uh, payment system. There are also setting standards of clinical care, which is right now being undertaken by PMGA, AY. By using clinical practice guidelines and HTA to improve provision of care. We also did the pre-authorization policy for certain benefit packages like cancer and chronic, particularly chronic diseases. And lastly, an important feedback mechanism should be installed. And this allows wider stakeholder engagement, particularly from the member and from other interest groups like civil societies, would actually provide a robust feedback towards how we can actually improve uh, accountability and governance for strategic purchasing. Here in the Philippines, we are looking at expanding the uh, board membership of the health insurance to include primarily um, civil society organizations, other interest groups, not only uh, national agencies or national government agencies, but in providing a more inclusive platform for the other sectors to be more engaged uh, in, uh, in setting up a accountability mechanism by which the health insurance and other purchasers, national government, local government will be more accountable to. Uh, so basically, these reforms, which I actually hear from Sumit on how they're moving with their national health insurance program, is similar to the journey that we're actually doing here in the Philippines. And I think there's a lot of similarity, not only in terms of the reforms, but also in terms of the period. I guess the Philippines about two decades in terms of its experience in establishing a health insurance program, and the journey wasn't really that smooth, but we've learned a lot a long way in terms of ensuring that governance and accountability mechanisms should be put into place so that we can be able to not only uh, be more strategic in our purchasing function, but be able to be more efficient in terms of using the finances, more equitable in terms of the provision of quality of health services, and be more be able to increase the population coverage for the country. I would say that right now the Philippines is really moving towards a 100% coverage with the UHC law that was recently passed, everyone is automatically covered under the health insurance, and it's a really great joy to see things are happening quite rapidly after the legislation has been put into place. And I think similarly, a lot of countries would also learn from this particular experience. Sometimes many reforms doesn't really move as we wanted it, no? But if we're going to put a pressure in terms of making legislating it into a law or a bill would really help a lot in moving, not only resources but moving a lot of things in the health sector. We can move things much better, much faster forward. So I guess that's what I can actually share from my side. I hope you've also got some insights from that. So thank you.
Excellent. Thank you very much. Some really interesting points that you've raised around capacity building, the need for accreditation, various accountability mechanisms. I see folks have started to send some questions over the chat function. We can start with those and then move into others if we have time. You're all able to unmute yourself as you want to ask questions. So let's just begin with the ones that we've been sent so far. So we have one from Edward Owino on how do you identify who to pay and who not to pay for insurance using PMJ. Sumit, this is over to you, and I think the next few questions as well, which we'll read out before responding.
Yeah, I think great questions as expected, and so I think no, Edward, like nobody pays in PMJY, so there are very stringent measures through which, based on some large nationwide surveys, there is a lot of different criterias in rural and urban areas based on which the eligible beneficiaries are identified, and they have to apply to get themselves enrolled in the program if they satisfy those criteria. And once they are enrolled in the scheme, they don't need to pay any premium or anything for insurance, and it's entirely cashless hospitalization for over 1300 years. So no, nobody pays under PMJY any premium. Probably that answers the question. Nidhi has asked, like, what are mechanisms to prevent fraud? I think I briefly uh, touched upon in the presentation, and there I'm happy to share other details if you write to me. But I think the main thing is, like, uh, the first is, of course, the pre-authorization, which was not there in RSBY. So hospitals cannot straight away book a claim or file a claim, which they have to get pre-authorized, and even after, which is basically submitting clinical imaging diagnostic documents before the procedure starts, like as you do for other emergency hospitalization procedures for private insurance, as well as after the patient is discharged, is need to upload documents regarding discharge summary and clinical other proofs. So there is a stringent authorization process. There is also a lot of mechanisms they are trying to build in, which is, they call it upcoding, as you might be knowing. Like, you go for a stent, for example, but you are billed for a like a angio, I mean a kind of a CABG, for example. So I think authorization is a major step, as well as clinical audits, which is being planned and being piloted in some states, where you pull up a sample of hospitals for the claims and very detailed check the claims. So I think those are the new ways in through which it is being done. And regarding your point on getting, so I think a lot of states have gone for either the trust model or a mixed model, which actually limits the private insurance involvement. And also, there are what they call as insurance support agencies, which are non-insurance, more actuarial, semi-autonomous agencies to kind of as an additional layer to job look into this. And yeah, so there that is perhaps one something which is being tried under PMJY. Swati Srivastava asks uh, about, yeah, thank you, Nidhi. Swati asks like how quality standards. Yes, I think I have been seeing like there is perhaps one of the first uh, comprehensive effort. Of course, as you might be knowing, like NABH, which is the National Accreditation Bureau of Hospitals in India, has been giving quality accreditations to hospitals, but now under PMJOY, it has been explicitly made. I think it is a very clear indicators across different domains and very easily. So there is a, if you see the PMJOY website, there's a fantastic document which shows with pictures that how could you actually verify whether a hospital adheres to those quality standards, and based on that they can claim a premium. Like if you go for a bronze category, you get a 10% premium, and then you gradually go to about 15% to 20% premium over the package rate. So that is an incentive to that built in into that. Regarding clinical establishment, if you're familiar with the Indian health scenario now, there's been a lot of pressure, but actually the onus to implement clinical establishment act is on the states. Some states are trying. Very recently, 2 days back, the government of Delhi had presented a bill to to do clinic. I think it's not problem with the act, but if I think which might also kind of talk of Ipshita's question, that it's lot depends on the local state level capacities of implementing clinical establishment, implementing quality standards, implementing local capacities require a very elaborate scheme of monitoring, audits to kind of go. And depending on the size of the market, like any Indian state is, most of the Indian states are larger than most European countries. So thinking of the capacity of the state to monitor such a unregulated heterogeneous market and enforce quality and clinical establishment standards is a big challenge. But what PMJY has started baby steps is to move towards having a system to kind of do that. Regarding, I would just add one last comment is actually it's not only bureaucratic administrators. If you see, the I was just reading some, thinking of the Medicare setup in the US, which is not, of course, a fantastic example of health insurance, but uh, uh, even see the manpower that is involved there. Like, India simply doesn't have huge technical capacities required at the state level, like actuarial scientists, insurance experts, claim analysts, statistical persons, modelers, familiar with regulatory environment. So, a lot of these support staff, these capacities needed to be incubated. We don't have any, very few training courses in India which familiarizes people to who are willing to take for this kind of monitoring and effectively kind of implementing, regulating, supervising, auditing of these claims. So I think it's a kind of new paradigm which has been there, which, and I think the success of whether or not is could be possible lies in enforceability and on capacities and how best. So I don't want to take much time. How best other markets for healthcare respond to it, like markets for medical education, for example, and with not just doctors but medical technicians, medical support staff, uh, which kind of builds the ecosystem which is required to carry forward these governance initiatives and quality. So I think a lot depends on how these responses submitted. Not to forget, JOI is covering just a chunk of India's 40 to 50% of the population, 40% at most. A lot more is outside the services. So I think of how JOI would be a good baby step, a good benchmark, good template. Start doing these basic things, and then perhaps which could be implemented at a wider level. Uh, Another question, if I may, Daniel. There is a question from Nina. You mentioned strategy governance. Yes, excellent point, Nina. Just there was a tweet this morning, and I responded. So there was a suggestion that ESIC, which you might be familiar with, which is a kind of formal sector employee insurance scheme. They have about 18,000 beds. So there has been a proposal to the minister, was just probably saying a couple of days back that whether to kind of combine these beds with those under PMJY. I think it's a very good idea in principle, that how you can harmonize these schemes together, existing formal sector schemes. And I think it's there has been some discussion onto that, which perhaps might be taken up, as well as there might be provisions. I think it's easier with, if you're familiar with ESIC, but thinking of CGHS, which is more clinic, I will more challenge on how you weave it with and the primary care. Yeah, thank you very much.
Thank you. Thank you very much, Sumit, and to Jaker for your great presentations, and Sumit for the great responses, the very clear responses that you've given to the questions. Thank you all for your participation. We're just moving to the next, to the last slide where you can see the next upcoming webinars in the series. We really hope that you'll join us. And please also look, we'll be posting this webinar on YouTube so that it will live in perpetuity. And we look forward to speaking with you all next in November. Have a good rest of your day and evening, everybody.
Yeah, thank you very much, and happy to have any questions. The email and IDs are there, so and hopefully the presentation would be on the collectivity site soon, so you can go through them and let me know if there are questions. Thank you very much for being present.